The third category of medication perceptions that decrease adherence were those related to negative effects of taking medicines. Some reported concerns about side effects such as weight gain, impaired growth, the general safety of corticosteroid medicines, or the potential for dependency on or addiction to controller medicines. Note, the patient may not be experiencing the side effect, but stop the medicine because they are concerned about developing one. Patients also reported non-adherence because therapy was inconvenient. The category would include adjusting regimens for their schedule or stopping medicines because of adverse effects or dislike of the taste of the medicine. Important interventions in this area are to be open about potential for adverse events. List common ones and importantly how to avoid them. For example, avoiding thrush or hoarseness with inhaled corticosteroids by rinsing their mouth after each dose, but reassure them of the relative safety of long-term therapy, especially in relation to the risks of not treating their disease. Also, that inhaled medicines are relatively safe compared with oral medicines. Asthma or COPD symptoms worsen when medicine is stopped, but that is because these diseases are still there. The flare in symptoms does not mean they are addicted or dependent on their medicine, nor will the medicine stop working if taken every day. Discuss their particular schedule and lifestyle. How can taking this medicine be most conveniently integrated into their daily routine? The adherence estimator is a brief 3-question tool that can be useful to screen for concerns and start conversations about a patient's barriers to taking medicines. The website for this tool is listed in the references. Non-adherence because of perceptions of their disease included modifying medicines based on how they felt. Patients reported discontinuing medicines when their symptoms improved. They believed the medicines were not needed because their condition was better. It is possible that this perception is more common for asthma because symptoms are more variable over time and may be intermittent. But patients also reported taking more medicine than prescribed when symptomatic. This could include both controller as well as quick reliever medicines. The other perception affecting medication adherence was their vulnerability to their disease. Is there a serious consequence from not taking medicine? From the patient perspective, if asthma or COPD does not flare immediately after missing a dose, perhaps the medicine is no longer needed. On the other hand, if hospitalizations from asthma or COPD progression are inevitable, why not wait to take the medicine until it is really needed? Important disease messages include neither asthma or COPD are curable. Depending on the disease severity, they may need medicines for their entire life. Be honest about the how medicine can impact their condition. Unfortunately, many with asthma accept symptoms and limit their activities because of poor disease control. With the right therapy, they should be able to live a normal life and be as active as they wish. Their breathing should not keep them from the same activities as others their age, even competitive sports. Ideally, they should never need to be hospitalized or need urgent care. But asthma is a serious condition. It is very important for them to have and understand an action plan so they know how to manage asthma flares. For COPD, the expectations of therapy are usually much more modest. They might need to accept that medicine will not make them symptom-free. Having less frequent hospitalizations or exacerbations may be the goal, or perhaps maintaining fairly normal activities such as housework, work schedule, shopping, and so forth. COPD is progressive, especially if they continue to use tobacco, so more medicine might be necessary over time. This data helps us understand how patients view their medicine and how this affects their adherence to medicines. In another study, patients reported how their provider's behavior affected their adherence. Patients said that they were more adherent when their providers communicated clearly, understood their beliefs and perceptions, answered their questions, spent time with them. About 30% of patients reported that they received no instructions with a new prescription. Of those that did, 62% said that they only received instructions on how to take the medicine rather than the purpose or adverse effects. How can we as healthcare providers exhibit the behaviors that patients say will improve their adherence? Based on this data, we make the following recommendations. Let's start with the first issue, communicating clearly. Using clear communication strategies can prevent non-intentional or primary non-adherence. Use standardized terminology that is recommended in disease guidelines. For example, use terms like quick reliever and controller for asthma medicines. This helps make messages consistent across providers, but avoid unnecessary abbreviations or jargon. Reflect back the language and terminology used by your patients. For example, there are several alternative terms a patient might use for their sputum: phlegm or mucus or spit. If the patient uses phlegm, then switch to using that word. Use the brand or generic name that the patient uses for their medicine. Be specific with instructions. Is this new inhaler in addition to, or does it replace other inhalers? How to take medicine. For example, what does as needed for shortness of breath mean? Is short of breath meaning trouble catching my after climbing stairs, or only when I am in dire need? Patient-specific asthma and COPD action plans are always to provide objective methods. These care plans offer guidelines on when to take more medicine for an exacerbation, or when to seek urgent care when exacerbations are worsening despite medicine. The what-if technique can be useful to verify understanding of how to apply information. For example, what if you become wheezy during gym class? What would you do? Provide examples or relate information to their circumstances. You might start by asking them to identify specific activities in their home, school, or work life when they have breathing problems. Examples might include hot muggy days or exposure to their asthma triggers. Help them brainstorm one or more solutions to successfully modify their medicines in those situations. Assess their understanding using the most appropriate verification technique. We have already talked about two of these. Use teach back for facts like how often and how many puffs to take. The other was the show me method for skills like device technique. Two other helpful verification techniques are chunk and check. This technique is very useful for information-dense, complicated, or lengthy topics. To chunk and check, break up the topic into manageable pieces or chunks. Then use the appropriate technique, teach back or show me, at the end of each piece. This way you can make sure that you've not lost the patient somewhere along the way. Another useful verification tool is what ifs. This technique assesses if patients can correctly adjust medicines in different situations or apply their action plan. To use the what if technique, provide a situation the patient is likely to run into and then ask what they would do. So, what if you catch a cold and become more wheezy? What would you do? What if after following your yellow zone care plan for 3 days you are still wheezy? What would you do now? So what will you do the next time before you visit Grandma and her cat? The verification process will provide a routine method to clarify, correct, and emphasize key information. Sometimes the information or skill may need to be repeated a few times before there is full understanding. Patients also want us to understand their perceptions of their medicines and condition. So, have candid conversations exploring their perspective. Ask if they have any problems or concerns with their medicines, including side effects or potential for side effects. How do they feel about the number of medicines they are taking or the number of doses? Is the amount of medicine acceptable, too little, or seem too much? Do they feel the need to make adjustments in the way they are taking their medicines and why? For example, because it was more convenient for their daily schedule or because the medicine didn't seem to work? Do they use non-prescription or alternative medicines for their breathing in addition to or instead of their prescription medicines? Why do they use these medicines? Do they perceive them to be safer, more effective, or provide a benefit not seen with their prescription medicines? What are their expectations of their medicines? Do they have misperceptions that the medicines will cure their disease? How is the disease impacting their life? What are their goals? Are their medicines perceived as valuable and affordable? The last two issues patients identified were for healthcare professionals to spend time with them and to answer their questions. The conversations we have with patients do not need to be long. Ask, what questions do you have? This indicates that questions are expected. Listen carefully before responding. Seeking their perspective, encouraging their questions, and addressing their concerns will hopefully provide the perception that adequate time was spent with them. Next is a short video of an interaction between a pharmacist and Mr. Jones, a patient of a child with asthma. Consider how the pharmacist explores the cause of the child's asthma exacerbation. What type of non-adherence is being exhibited? What is the issue that is blocking adherence to controller medicine? If you were talking with Mr. Jones, what do you think would be the most appropriate messages that would increase adherence and avoid future exacerbations?
Hello, Mr. Jones. I'm Teresa, the pharmacist. I've talked with your wife a couple of times about little Billy's asthma.
Yes.
I'm sorry to hear he had a bad night. Fortunately, he didn't need to go to the hospital this time. I wanted to chat with you to see if we were doing everything possible to prevent more of these episodes. Do you have a couple minutes?
That would be great.
According to the notes, he seemed fine until bedtime. Tell me more about what happened.
Well, we went to his soccer game as usual. He took his blue puffer before the game and was able to play the whole time. After dinner, he seemed tired, but I thought that was because of soccer. He woke up about 1, coughing and wheezing. Sue gave him a neb treatment. That helped, and he went back to sleep, but he woke up again about 6. I gave him another treatment and a couple of puffs of the pink puffer too. He still seemed a little wheezy, so I brought him in this morning.
Well, you did the right things. It was good to give him a dose of the quick relief inhaler, the albuterol, before the game so he could keep up during the game. And it was really smart to give him the second treatment and then bring him in when he wasn't back to normal. How are you using the pink puffer? That puffer has the controller medicine, the beclomethasone or Qvar.
To be honest, we're just giving him the blue one. We gave him that other one a few times. It didn't seem to help. And why give him something every day when he only wheezes a few times a week?
So you're reluctant to give Billy a controller every day because you don't think his asthma is bad enough to need a medicine every day. Tell me a little more about that.
He has missed some school, but hasn't had an attack bad enough to go to an emergency room for months. My wife read the information on it. She is worried about Billy taking a steroid medicine every day, possibly for the rest of his life. Our copay on the pink puffer is pretty high, especially since each one only lasts a month. It made more sense to save that for when he really needed it, but frankly, it sure didn't do anything this morning.
So you're concerned about the cost and then the long-term effects of a daily medicine on a 6-year-old. Is that right?
Yeah, that's right.
There are no generic controllers, so the controller seems really expensive and he needs a new one every month. May I tell you some of my concerns about Billy's asthma?
Yeah.
You told the doctor that he wakes up a lot at night. When he has an asthma episode like this, he misses school. I'm guessing that asthma is affecting Billy's schoolwork. What do you think?
Well, he has missed several days of school this year. He's a really smart kid, but his grades aren't that good.
So you want him to do his best at school and give him the least amount of medicine. Think of it this way. During every attack, Billy takes lots of prednisone, which is a steroid too. But by inhaling the steroid, it goes right to the lung. So only a teeny tiny dose of the steroid is needed in a controller. 2 puffs of the controller twice a day might actually mean much less steroid medicine overall. The controller seems costly, but those emergency visits and extra doctor appointments are really expensive too.
Right.
If he has fewer attacks, he might do better at school. Is that worth a try?
A little every day instead of a lot for an attack?
Exactly.
That makes sense to me. If I explain it to Sue that way, she might be willing to try it too. If he takes 2 puffs before school, can he wait until after supper for the second 2? Because we often don't get home from soccer until then.
Either after supper or even bedtime would work. Whichever would be the most convenient for you every day.
Okay.
We can put a reminder sticker on each puffer. The green sticker will say controller medicine and the yellow sticker will say quick relief.
Okay.
That way Billy can learn to tell the two apart. Let's look at the insurance tiers again to be sure that this controller has the lowest copay for you. Could you track his nighttime asthma episodes, any missed school days, and extra puffs of albuterol? If any or all of those were less frequent, we would know his asthma was better.
I could do that on the calendar on my phone.
That would be great. When you bring him back next month, we'll look at that together. Be patient. Controller medicines can take several weeks for the full effect. That may be why you didn't see any benefit before.
Okay, got it.
But if next month his asthma is not at least a little better, there are some other controllers we can try. The nurse said Billy was pretty good breathing in the medicine today with his spacer. Use that tube with this new puffer too. What questions do you have for me?
I think I got it.
Great. If you or your wife have any questions, please call me here.
All right. Thank you.